Hello, my dear gynecologists and surgeons. Endometriosis and endometriotic cysts. In a case of primary infertility, 27-year-old lady symptomatic with discomfort, pain, and infertility. There you can see a supraumbilical camera port, two ipsilateral working ports, 5 mm one, and that's the right ovary. You can see the fallopian tube stretched out, and that's a cystic structure that looks like a chocolate cyst, and the uterus has been lifted up using a small uterine manipulator, and there you can see the left ovary hidden behind. So what will be the plan? The plan is obviously to do the removal of the chocolate cyst and saving both the ovaries, as she is a young female with primary infertility. A chromoperturbation will be done in the end of the surgery. So I think that's what a complete surgery will be, and you can see a bit of adhesions down below in the pouch of Douglas, and there comes in the aspiration needle aspirating the chocolate cyst. The chocolate cyst is a very thick cyst, as it is the blood that has been marinating the tissues inside, and it's the chocolate. And what is this endometriosis thing? A disorder which the tissues normally lie in the uterus grows outside the uterus. That means the endometrium is secreting somewhere else, where it could be the fallopian tubes, the ovaries, the intestine, the peritoneum, and anything in and around the uterus. Sometimes in operative scars also they tend to stick and cause lots of problem. The symptoms, the menstrual pains, and there you can see I have opened the cyst, aspirated and opened. I'll be using bipolar shearers only over here, and as it is a very safe and a very good instrument, there I have opened it, sucked out all of its contents so as to avoid spillage. Minimal spillage should be there. And now, as the plan is to save the ovary, I'll have to take out the cyst. So how do we take out the cyst? Obviously we'll be stripping the cyst apart from the ovarian tissue that is lying outside. So I'll be using a Maryland grasper, slow and steady, step by step. Nothing great in the surgery. You can see the bigger side I am trying to take it out. The Alice forceps pulling it toward one side and Maryland pulling it towards other side. It may look a bit frustrating. Please don't worry. Keep continuing this dissection, as we don't want pieces of this endometriotic cyst remaining here. The same can be done with dermoid cyst, simple cyst, and any type of cyst of the ovary if you want to save the ovary. Else, a salpingo-oophorectomy is the easiest option, but should not be tried, especially in young females, as the ovarian tissue has to be saved. So what's the cause of this endometriosis? The main cause, obviously, retrograde menstruation. This is when menstrual blood flows back through the fallopian tubes and into the pelvic cavity instead of outside the body through the vagina, as these fallopian tubes are connected and to the inside of the abdomen. Endometriosis has a significant social and public health issues. It can decrease quality of life due to severe pain, fatigue, depression, and anxiety. Some individuals with endometriosis experiencing debilitating pain that prevents them from going to work or even school, as when the menstruation starts, the endometriosis starts at that time only. Endometriosis is generally graded as stage 1 to stage 4. In stage 1 there are few small implants, red to black spots spread over the peritoneum inside. Stage 2, these implants are a bit more with the bowel sticking to them, and stage 3 are more deep. They go across the peritoneum and cause severe adhesions and pain, and the pain is typically at the time of menstruation, but when it is deep and cause of adhesions, the adhesions itself cause pain because of the colics, the intestinal colics, and the patient can even land up in intestinal obstructions. And in stage 4 endometriosis, the ovaries are typically involved, and this is theoretically a stage 4 endometriosis, but a stage 4 endometriosis may not be that symptomatic because it is a contained thing, but somehow theoretically this means a stage 4 endometriosis. So there you can see I am trying to pull out the chocolate cyst, and look how easily it is coming out. Not easily though, as it has marinated the cyst inside. There is quite a lot of adhesions, and I am using quite a bit of force to pull it out. And don't worry about the bleeding. If the planes you are following is correct, as you can see over there, bleeding will be almost nil to minimal. So no issues. Just improve your skills, hold the tissues nicely and tightly. Your hand grip should be good enough so that you can pull it out. Here you can see step by step traction and counter traction. That is the key of surgery. Holds true with laparoscopy also. So that's the right ovary that we'll preserve. And there you can see the patient is planning for a pregnancy obviously, and once we remove these endometriotic cysts, her symptoms will improve, the pressure on the fallopian tubes will go down, and once she is pregnant, the symptoms of pregnancy will disappear. So coming to endometriosis again, is endometriosis curable? Obviously no. Till the woman is menstruating, the ovarian functions are there. There is no treatment of endometriosis. It is like a cancer that will not kill. And if it is in stage 2 or 3, that means the peritoneal deposits are there causing adhesions of the bowel. The symptoms are very severe. The only answer is medical management. There you can see the complete cyst has been excised, nice and beautifully excised, and there's the stretched out ovarian tissue and a bit of tissues left that has to be hand picked nicely. You can see almost a complete excision of the cyst, and we'll search for if any cyst is there may be, so we have to remove that also. A thorough search is required, and there you can see in the first look it feels that everything is okay, but you should always suspect something more cyst in a case of endometriosis. So that's the ovarian tissue I am holding on the right side. Quite a bit of ovarian tissue that is remaining. So, and maybe in 2 to 3 months this will shrink to form a normal ovary. They are searching for endometriotic cyst again, as I was in doubt that something bulging laterally is seen, that I have to pull it from inside. You can see doubts are always there. It's like a policeman. The surgeon should also always be in doubt. That boggy structure has to be something. We can't leave it there. And later on the USG will show a chocolate cyst remaining, and that will be bad. Though initial ultrasound was not showing it, as the first cyst was so big that the ultrasound could not differentiate it. But still the search continues, and there you can see the blood stained structures that's causing a doubt. It is slipping. I should not hold it that tight also, and the structure excision should be very precise, as what you call surgical precision should be there. There you can see the bluish structure, and that's a cyst that I have found now, and this also has to go, else I'll be doing an incomplete surgery. So be patient, go step by step, no hurry, and be watchful. And if at all you are in doubt, please ask your camera surgeon or the anesthetist that if they see anything else. So respect their opinions also and watch. And there you can see I found one more chocolate cyst there, and now this also needs excision. As far as laparoscopic surgery is concerned, it's one of the best surgery a woman could get. In this era of laparoscopy, what I feel that no abdomen of a woman should be opened for any surgery, any disorder, any illness, other than the physiological condition, that is obviously pregnancy. You can't do a cesarean section with a laparoscope. So there dissection continues. I am not using any current or thermal things, as the ovary has to be saved 100%. No thermal injury should be required. Will not be using any bipolar or monopolar. No electricity, no current to be used. Just push and pull, and if you are in the right plane, nothing else is required. This ooze will stop automatically. No drains, no tranexamic acid, nothing should be required. There you can see the whole game is traction and counter traction. And we at Laparoscopy Lancers are teaching the art of laparoscopic surgery. So you can join us as an observer as the scroll is coming down. You can WhatsApp me, join us. We do a lots of general surgery and gynae surgery. I have around 35 hospitals associated with me. The plan in this is that you will be accompanying me as a freelancer. I am doing freelancing in quite a bit of hospitals. We have 2 hospitals of our own in Himachal Pradesh. The epicenter of this laparoscopy lancers training is at Chandigarh, and you will get a chance to observe all variety of cases that are the bread and butter of a gynecologist and a surgeon. Hundreds of laparoscopic cholecystectomies, laparoscopic hernia surgeries, total laparoscopic hysterectomies, laparoscopic myomectomies, all types of lap hernia surgeries, and sometimes gut surgeries and malignancies also we get. As in private practice, small setups, we generally don't get bigger cases. And obviously the bread and butter is a cholecystectomy or an total laparoscopic hysterectomy or ovarian cyst surgeries, and sometimes appendicectomies, though these emergencies rarely come to an private setup, but still we have quite a lot of them. We are doing around 100 to 150 surgeries in a month, and if you become a good observer, obviously you will learn the surgery. That is the way how we learned. Nobody taught us hands-on, we learned by ourselves only. And there the second cyst, look how big it was. If I would have been happy with the first cyst, this second cyst would have left and it would be a very big blunder. So be cool, be patient, and keep searching. And if you search, you can even find God, as the preaching goes. So step by step, there the dissection is complete on the right side almost. I have inspected everything, and there you can see the endometriotic cyst has finally coming out, and it has come out. Hello, that's the 2 cysts. Now a bit of inspection again, and I'll be sucking this out. As you can see, no pink blood, that means no fresh bleeding is there. That's a bit of ooze. You do not need to worry about it. Just suck it a bit. Sucking is required because in the post-op these blood clots may cause pain. The thing is, it may cause pain, not always. As you must have heard and seen also, hemoperitoneums do not cause any pain. So do not be so aggressive with the surgeries, and those yellow things are due to chronic inflammation. Those honeycomb like things, gelatinous things, sucking them a bit, that's just a time pass, nothing more. So as we were talking about endometriosis, there's currently no cure for endometriosis. I repeat, there is no cure for endometriosis. You can only decrease the symptoms, and ovarian ablation is the only answer, because endometriosis is the endometrial blood that is getting collected. The only thing that the things we do operatively is remove the adhesions and the bigger things of endometriosis, and then control it with anti-estrogens. The symptoms will be relieved. So endometriosis is a chronic condition, meaning there is no known way to permanently eliminate it. However, various treatment can help, as we are doing in this case. This is for treatment of infertility in particular and relieving the pain. The pain relievers over the counter like Combiflam, Dolo, and any Eslophinac, any pain relief medicines can manage pain and discomfort during the period. Then there you can see a window that is formed over here. That's the ovarian tissue. I am looking through the ovarian tissue. Nothing much to be done over there. It's not an opening in the broad ligament, and just the opening behind the ovary and the mesoovarium. That's the space that I am seeing. It's not a through and through opening, so no worries, no need to close it. and don't worry, no hernia will form, and there will be no strangulation of the hernia over there, so we can leave it alone. So the medication after the pain relievers, there are the hormonal contraceptive, like even the birth control pills, patches, injections can regulate menstrual cycles and reduce the growth of endometrial tissues. Other medications like danazol and GnRH analogs can suppress estrogen levels and reduce the growth of endometrial tissue. So, idea is to reduce the growth of endometrial tissues. And when is the role of us surgeons? Laparoscopy. This keyhole surgery can diagnose and treat endometriosis by removing endometrial tissue and the scar tissue, obviously. So, we are basically debulking the endometrial tissues. And a hysterectomy, in some cases, removal of the uterus or the ovaries may become necessary to relieve pain, but this is usually a last resort. And sometimes the adhesions are so much, lots of adhesions are there, and if you feel that doing adhesionolysis will injure the bowel or any other vital structure, please do not go ahead for the surgery. Please give anti-estrogens, stop the estrogens, and give a lots of NSAIDs, and chymotrypsin these days are very excellent in relieving pain. Go for medical management. Tell the patient, counsel her that heroic surgery will never help her. It will cause more of a problem. So that's the left ovary. I have aspirated it. The chocolate tissue has been aspirated. Now the thing is to take out the cyst inside it, and again we'll be saving this ovary, as saving is more important. You should not do a drastic surgery over there, just opening the thinnest part of the cystic structure that I had seen. Generally we use only 2 ports, and please practice using 2 ports only. We are doing all the gynecological surgeries with 2 working ports only. That means you can say it's a 3-port surgery. Contralateral ports I've not been using since maybe 3 to 4 years, as contralateral ports cause a problem to your right shoulder and obviously to the camera surgeon, and even a strain to your back and the neck. So practice with ipsilateral ports only. The speed is same, or maybe even you will be faster using ipsilateral ports. Even in total laparoscopic hysterectomy, a myoma screw is never required. Please forget or leave the myoma screw for total laparoscopic hysterectomy. A vaginal manipulator from below is enough for manipulation, and even the biggest of the uteruses can be removed with ipsilateral ports. You can watch lots of videos on my YouTube channel. You can go back, scroll, and see how we take out even the biggest of the fibroids and uteruses. And even laparoscopic myomectomy, again 3 ports are good enough, 4th port is not required. Earlier we used to use myoma screw almost in every cases when we had no idea. Now obviously we have graduated, improving the skills. That is the most important thing. So there you can see the tissues are separating, traction and counter traction. And please learn laparoscopic surgery. If you have any bent towards doing surgery, you should go towards laparoscopic surgery. And if you are in a fix that how to learn, please do join us as an observer. We'll teach you all of the art of laparoscopic surgery. If you want a good hands-on, you can do bigger or longer courses with us, and even you can join our hospital at Kullu and Mandi, Himachal Pradesh. Both are very beautiful places. You can work up your own patient and operate on them with my expert supervision, and you will become a laparoscopic surgeon in maybe 2 years or so. And your early 2 years of life as a gynecologist or a surgeon learning laparoscopy, it will be great. You will be a very expert laparoscopic surgeon for next 30 to 40 years, obviously. So please give some time, and you can always join me. I am open for you to join our hospital as a surgeon or a gynecologist at Kullu and Mandi, Himachal Pradesh. So there, All the chocolate cysts have been removed, nice and clear. There is no evidence of any hemorrhage. The thing that you are seeing, that's oozing, that will stop by itself. We have not given any Trenexa to the patient. There you can see as the blood is getting darker, that means the clotting has started. The patient has a normal bleeding time and clotting time. Removing all the bit of endometriotic tissues from the ovaries, and practically she is cured of endometriosis as far as the ovaries are concerned, and she will get pregnant normally after maybe 1 or 2 months of this surgery. As the fallopian tubes are clear, we will not be showing the chromoperturbation in this case, as the recording was done on the other system, as hysteroscopy was also done, so that's not there in this video. And obviously both tubes are very well patent. That's the blood, you can see clotted blood. If there is no pink blood, that means no issues. And you must have noticed that other than cutting the ovaries, the initial incision, I have not used any thermal injury over the ovaries. No thermal things for hemostasis, as generally most of the people tend to do carpet bombing over the ooze. So please do not do any carpet bombing over the ooze. Let the body handle it. And there I have put in an improvised endo bag. Please tell in the comments what that endo bag is made of. I repeat, what is that endo bag of? Obviously it must have been a container for something else. We have sterilized it and put it in, and whole of the endometric tissue should come out with a endo bag, obviously, because there is chances of implantation of endometriotic tissues in the scar. So the patient should not have any scar endometriosis, and that's a very difficult and painful thing, a scar endometriosis. So please use an endo bag after thorough cleaning and suction. An improvised endo bag, obviously. And I'll be dilating the left lower port, that is just above the anterior superior iliac spine, into a 10 millimeter port, so that gallbladder grasper comes in and the specimen can be taken out. So the surgery is almost complete. Only the formalities remaining, just a bit of suction, that is all required. And I repeat again, you can join us as laparoscopy lancers. We are teaching the art of laparoscopic surgery, and our motto is an abdomen of a female should never be opened other than in a elective cesarean section or a emergency cesarean section that can't be avoided. My number is given below on the right lower corner of the last slide, you can see. And there the surgery is complete. Look, a piece remained over there. You should inspect everything, and that also goes in. There you can see, sucking out all the tissues and sucking out even the tissues over the grasper. Your surgical hand should be so good that it should feel as if your hands are inside. That's the most important part of laparoscopic surgery, the dexterity and hand-eye coordination. That is the most important thing, and the instrument coordination. There you can see the gallbladder grasper, the endo bag, and that I have held nicely and pulled it out. I've dilated the incision a bit, and these tissues will come out normally. So thanks for watching the surgery. Please do like, subscribe and comment, and join us as an observer if you want to learn laparoscopic surgery. And we have lots of hands-on thing also if you are willing and you are a very keen observer. So friends, thanks for watching. These are the pictures of a few laparoscopy lancers that had joined us a few months to few years back, and all have learned laparoscopic surgery. They are all doing very good in their own private practices in various parts of India, and one of them has excelled in South Africa also. So you can join us as observers in laparoscopic lancers. We are teaching the art of laparoscopic surgery. We are starting a 7-day, 14-day and 21-day courses, details of which shall be available on this YouTube channel and our website www.laparoscopylancers.com shortly, and even you can WhatsApp me on the number that is displayed on the screen. So thanks for watching and keep in touch. Do like, share and comment on the this video. Your opinions will be welcomed. Thank you guys. Thank you so much.